Dilatation of strictures by TTS through the scope balloons has revolutionized management of colonic strictures, especially post-operative ones. Fully informed consent is needed beforehand. The patient must realize that post-procedure pain or perforation can happen. Literature series quote between 6% and 11% perforations. More perforations occur with larger balloons, but they may give better long-term results. Which diameter balloon to choose also depends on circumstance. For a tight fibrotic stricture, a 12 to 15 mm balloon may be wise. It's always possible to repeat another time with a larger one. 18 mm is a good compromise, but even a 3 cm diameter balloon may be needed in the left colon. The revolution in dilatation has been the new generation balloons, ultra-thin but extremely tough, allowing them to have a guide wire inside, but keeping the diameter small enough to pass easily through even pediatric instruments. With older, reusable balloons, a wide-channel instrument and silicone lubricant were used. With the new balloons, silicone spray or a little lubricant jelly is enough. Balloon dilatation must be with a gun and water because it's non-compressible. The pressure gun is used to reach and sustain the very high pressures needed, typically over 5 bar or 80 pounds per square inch, or psi. This type of gun is convenient because it also switches to deflate as well. Ideally, barium contrast study precedes endoscopic dilatation, and fluoroscopy is available during it, particularly for long or ulcerated strictures. In practice, many strictures are short post-operative narrowings and X-ray is not used. Having located the stricture, the scope must be manoeuvred so balloon access is as nearly straight on as possible, with minimum angulation, so insertion is easier and feel of what is going on is better. Except when there's an obvious view through the stricture, with any balloon it's wise to check first that the guide wire passes easily through with no resistance or excessive angulation. It's then easy to follow with the balloon and to water distend up to the correct pressure. Then to hold the pressure for 2 minutes before evacuating and withdrawing the balloon. Ideally, after dilatation, the scope should be able to be passed through to check things proximally, but this isn't always possible. Evacuation of the balloon is either with the gun or more quickly using a 50 cc syringe. It's easier to hold out the plunger with a hemostat or any spacer such as a syringe inner. It takes time to collapse the balloon sufficiently to withdraw it into the channel. To avoid tearing the balloon, sometimes the scope has to be withdrawn and the balloon furled by twisting a tube over it, which makes it easy to pull out.